Retinal tumors. Classification: vascular tumors, capillary hemangioblastoma, cavernous hemangioma, racemose angioma, and vasoproliferative tumors. Glial tumors: astrocytic hamartoma, acquired retinal astrocytoma, massive gliosis, and glioneuroma. Retinoblastoma, the commonest primary ocular malignancy of childhood, originating from primitive retinoblasts with 10. Incidence of retinoblastoma: 1 to 15,000 to 1 to 34,000 live births. Annual incidence: children younger than 10 years, 5.8 per million. Children younger than 5 years, 10.9 per million. Bilaterality: 33%, 100% hereditary. Familial cases: 6 to 10%, 90% diagnosed by the age of 4. The cell cycle. Normal cell cycle represents different phases of cell proliferation. G1 phase, presynthetic growth phase. Cells contain active hypophosphorylated form of retinoblastoma protein. S phase, DNA synthetic phase. G2 phase, premiitotic growth phase. M phase, mitotic phase. GO phase, quiescent phase. Cells contain active hypophosphorylated form of retinoblastoma protein. Cyclins are regulatory proteins controlling the cell cycle. Their regulatory function is accomplished by binding and activating cyclin-dependent kinases, which control the important transition points in cell cycle through phosphorylation or dephosphorylation of other proteins. Cyclin CDK complexes are regulated by the binding of CDK inhibitors, which are important in regulating cell cycle checkpoints from G1 to S phase. At this checkpoint, the cell ensures a flawless DNA replication with all errors repaired before progression to cell division. This checkpoint is guarded by retinoblastoma protein, RB protein. Inheritance: autosomal dominant, penetrance 90%. RB1 gene is a tumor suppressor anti-oncogene. Location: long arm of chromosome 13, band Q 1 to 4. RB gene. RB gene sequence contains 180,388 base pairs. The RB gene protein product, 928 amino acids, is a DNA binding protein found in the nucleus of every cell in the body. The DNA binding protein exists in two forms: an active hypophosphorylated form and an inactive hyperphosphorylated form. When the cells are stimulated by growth factors, RB protein is inactivated by phosphorylation. Phosphorylation of RB protein causes separation from E2F transcription factors, allowing the cells to go from G1 to S phase. Once in S phase, cells are committed to divide without additional growth factor stimulation, with lack of terminal differentiation, that is to say, cancer. RB protein is involved in controlling of the cell cycle, necessary for terminal differentiation. When active, RB protein forms complex with E2F transcription factor, preventing advancement of cells from G1 to S phase of the cell cycle. Tumor virus proteins, adenovirus EIA, and SV40 large T induce tumor formation by binding to and inactivating the active form of RB protein. The RB protein unable to bind to E2F transcription factors is functionally deleted, with subsequent loss of cellular ability to be inhibited by anti-growth signals. The retinoblastoma gene is inherited as an autosomal dominant disease. At the cellular level, it is a recessive tumor suppressor gene. Normal individuals have two functional copies of the RB gene, RB. Familial cases and sporadic germinal cases are hemizygous for retinoblastoma gene, RB capital, RB small, first hit, containing one functional and one inactivated gene. A single functional gene prevents malignant transformation. Tumors develop when the second hit is acquired as a somatic event in the developing retinal cell. Thus, both normal suppressor genes in a single retinal cell are lost or inactivated.
RB small, RB small. The absence of the gene product in the homozygous state leads to the development of retinoblastoma. In the hereditary form, two mutations occur in both a prezygotic cell and a postzygotic cell. Hereditary germline mutation. First mutation occurs usually in a sperm. All somatic cells are affected by the first hit. Second mutation occurs in somatic retinal cells, resulting in multifocal, unilateral, or bilateral disease or both. Second mutation may affect other cells of the body, resulting in pineal tumors, sarcomas, and so on. 13q chromosomal deletion. Retinoblastomas are familial cases. Gene deletion is karyotypically obvious. Systemic abnormalities include mental retardation, imperforate anus, genital malformations, facial anomalies including low-set ears, a broad nasal bridge, and a thin upper lip. Sporadic somatic mutation results from sequential inactivation of both genes in a single retinal cell in a patient with normal genotype, RB capital, RB capital. Tumors are unilateral because chances of occurrence in more than one retinal cell is exceedingly small. Most retinoblastomas are sporadic somatic. Diagnosis of retinal tumors. History: leukocoria, strabismus. We have to rule out familial cases and differentiate a case of leukocoria. Diagnosis: clinical presentation: leukocoria 90% of cases, strabismus 35%. Clinical presentation: fixed dilated pupil, neovascular glaucoma, heterochromia, hyphema. Spontaneous hyphema and unilateral ophthalmos in a child should be considered retinoblastoma until proven otherwise. Pseudo-inflammatory presentations: pseudohypopion. Any childhood intraocular inflammation should be considered retinoblastoma until proven otherwise. Orbital cellulitis-like picture, tumor necrosis. Proptosis, orbital tumor, congenital retinoblastoma. Other clinical presentations include phthisis bulbi. Gross pathology of retinoblastoma: white, brain-like mass with calcification. Growth patterns: endophytic, tumor grows mainly towards the vitreous. Exophytic, tumors grow mainly towards choroid, inducing retinal detachment. Mixed patterns occur in most of the cases. Diffuse infiltrating pattern. Its incidence is 1.5%. It affects elderly children, presents with pseudohypopion, and shows delay in diagnosis. Microscopic picture. The tumor arises from primitive retinoblasts with the ability to differentiate into photoreceptors and destroy the retina. Tumor shows blue, pink, and purple areas. Blue, viable cells with basophilic nuclei cuff around the blood vessels. Pink, eosinophilic zones of tumor necrosis. Seeding, spheroidal aggregates of viable tumor cells in the vitreous. Purple, dystrophic calcification mainly in areas of necrosis. DNA deposition around blood vessels, lens, trabecular meshwork, and internal limiting membrane. Signs of differentiation: Flexner-Wintersteiner rosettes, early photoreceptor differentiation, central lumen (SRS) filled with acid mucopolysaccharides, cellular apices joined by ELM-like zonally adherents, cilia 9+0 project into lumen. Homer-Wright rosettes, neuroblastic differentiation, no true lumen, neural filaments fill central space, often in neuroblastoma and medalloblastoma. Florets, advanced photoreceptor differentiation, small bouquet-like aggregates of benign-appearing cells, cells aligned along segment of ELM, found in less cellular areas of tumor, low nuclear cytoplasmic ratio, low mitotic activity, absent necrosis, and greater resistance to radiation. spontaneously regressed retinoblastoma, retinoma, retinocytoma. This is a benign variant of the tumor. Heredity shows germline mutation. Tumor appears regressed as if it were treated. Rarely undergoes malignant transformation. Bland nuclei with calcification. Prominent fleuret with no mitosis. Phthisis represents total tumor necrosis. Spread of retinal tumors. Tumor cells are discohesive. Tumor shows relentless progression, fills and destroys the eye, and spreads within vitreous. Tumor spreads in the anterior chamber. Scleral invasion occurs through scleral foramina, surgical wound if the eye is surgically operated. Optic nerve invasion to the chiasma and contralateral optic nerve via the subarachnoid space to the neural axis. Brain metastasis, direct infiltration of the optic nerve parenchyma to the brain. Hematogenous spread to the lungs, bones, brain with extraocular extension. Lymphatic spread with conjunctival invasion to the lymph nodes. Metastases occur within 2 years of treatment. Recurrence is due to retained cells in the orbit or beyond the point of nerve transection. Prognosis of retinal tumors. Risk factors associated with mortality. Invasion of ocular coats. Massive choroidal invasion, 60%, scleral invasion, and orbital invasion. Invasion of optic nerve, 5-year mortality rate. Optic nerve head, 10%, lamina cribrosa, 29%, not to cut end, 42%, to the cut end, 67%. Other risk factors associated with mortality include bilaterality and incorrect diagnosis. Also, risk factors include pineal gland tumor, second primary neoplasm, high incidence of development of second neoplasms unrelated to retinoblastoma. Incidence increases following radiotherapy. Risk for bilateral cases 30% after 30 years. Osteosarcoma of femur, skin carcinoma, cutaneous melanoma, rhabdomyosarcoma, Ewing's sarcoma, meningeal tumors, and Langerhans granulomatosis. Optic nerve invasion. Cut end, 67% 5-year metastatic risk. Not to cut end, 13% 5-year metastatic risk. Massive choroidal invasion, 8% 5-year metastatic risk. Exophytic tumors, high intraocular pressure with MVI. Optic nerve invasion. Enucleation more than 4 months after diagnosis, 4% 5-year metastatic rate. Trilateral retinoblastoma occurs in hereditary or bilateral cases related to loss of retinoblastoma genes. Intracranial tumor is undifferentiated neuroblastic pineal tumor, suprasellar or parasellar neuroblastoma. Staging of retinoblastoma. Rees-Ellsworth staging system predicts visual prognosis with external beam radiotherapy. Group 1, very favorable prognosis. Single tumor less than 4 disc diameters at or behind the equator. Multiple tumors less than 4 disc diameters at or behind the equator. Group 2, favorable prognosis. Solitary tumor 4 to 10 disc diameters at or behind the equator, and multiple tumors 4 to 10 disc diameters at or behind the equator. Group 3, doubtful diagnosis. Any lesion anterior to the equator. Solitary tumors larger than 10 disc diameters behind the equator. Group 4, unfavorable prognosis. Multiple tumors, some more than 10 disc diameters. Any lesion extending anteriorly to ora serrata. Group 5, very unfavorable prognosis. Massive tumor involving over half the retina with vitreous seeding. International Classification of Retinoblastoma. Since 1990s, chemotherapy was introduced as an alternative to external beam radiotherapy in inducing tumor shrinkage and ocular salvage therapy. RE classification became outdated. Retinoblastoma Staging System. International Classification of Retinoblastoma in 2003 is based on the rate of ocular salvage with systemic chemotherapy. A, B, and C, very favorable, tumor confined to the retina. D and E, unfavorable, tumor dispersed to adjacent spaces. F, unsalvageable. Group A, tumor not more than 3 mm, located more than 1.5 mm from disc, fovea. Group B, solitary tumor less than or equal 10 mm, more than 5 mm from disc, fovea. Group C, any size tumor less than half the eye, any retinal location, no vitreous seeds, no retinal detachment beyond 5 mm from the base of the tumor. Group D, subtle dispersion, fine vitreous seeds, no dispersed tumor masses. Group E, exophytic retinoblastoma, extensive dispersion, vitreous subretinal snowballs, lumps, clumps of tumors, avascular tumor masses in vitreous. With tumor dissemination inside the eye, treatment success decreases. This emphasizes the importance of early detection and improving tumor approaches to disseminated intraocular retinoblastoma.
Differential diagnosis: retinoblastoma 58%, persistent hyperplastic primary vitreous 27.8%, Coats disease 16%, ocular toxocariasis 15.6%, retinopathy of prematurity 7%, combined hamartoma 2%, coloboma 4.2%, vitreous hemorrhage 3.8%, astrocytic hamartoma 2.8%, retinal vascular hypoplasia 1.9%, rhegmatogenous retinal detachment 1.9%, X-linked retinoschisis 1.9%, medalloepithelioma 1.9%, congenital cataract 1.9%, retinal capillary hemangioma 1.4%, choroidal hemangioma 2.8%, peripheral uveitis retinitis 1.4%, toxoplasma retinitis 0.9%, idiopathic endophthalmitis 0.9%, Norris disease 0.5%, incontinentia pigmenti 0.5%, and morning glory syndrome 0.5%.